All right, in this lecture, we're going to look at the treatment of mental health disorders. I'm going to look at different treatment approaches that would include nutritional and others, and then we're going to focus on psychiatric medications because that'll be coming up a lot as we discuss the different disorders. And it's going to be important for you to know what the different classes of meds are, how we think they're working, and what some of the important adverse effects are from each class. So again, the kind of model we're going to use here is the therapeutic order. And there are 4 levels to this order. Level 4 being your need for medical intervention, and that's going to be referral to either a patient's primary care physician, or if they have a psychiatrist or mental health nurse practitioner, referral to one of those people. And that would be level 4 would be giving pharmaceutical therapy. And we'll look at the 6 most commonly used drug classes. That would be antidepressants, mood stabilizers like lithium for bipolar, anxiolytics, hypnotics, often used for sleep, antipsychotics, and that's used in schizophrenia or psychosis, and then stimulant medications. Paradoxically, those are used, central nervous system stimulants are used in the treatment of ADD, ADHD. And there are a number of somatic treatments that are also done in level 4, and that would be non-pharmacologic treatments that are really centered on the patient's body rather than the mind. So that would be electroconvulsive therapy. That actually is, we'll talk more about that in the depression section, but that can be an option for patients not responding to any medications where the depression is severely affecting their activities of daily living. That is an option there. And ECT used to be done with very, very large electrical currents, and that could cause secondary brain damage just from that. But now it's done in a way where it's actually fine-tuned to the brain's nervous signals, and the idea is it's sort of like a reset switch to kind of re-jumpstart some of the brain areas that maybe are hypoactive in depression. So that is an option that would be considered a somatic treatment. That's done now under anesthesia, so the patient doesn't feel that. Whereas before, patients were often awake during that procedure. Transcranial magnetic or deep brain stimulation. This is applying the pulsed magnetic fields to try to elicit electrical currents in the deep neurons at different structures of the brain. So that's becoming popular because it's non-invasive and it can have pretty profound effects on different mood disorders, for example. Surgery is rarely used except if there's like a brain tumor or maybe increased intracranial pressure, a shunt needs to be replaced, etc. So that would be some of the medical options. Now, we already went through the red flags in the last video, so make sure you understand those. But level 4 would be, again, hospitalization if there's increased suicide risk or homicide risk or lack of self-care. So that's level 4 therapies. But for many of our patients who present to adjunctive care practices, they might already have a PCP, they might have the mental health support, maybe with a team of counselors and so forth. They want to address it more globally, and so that's where we can bring in level 1, 2, and 3 here. So let's just talk about level 1. So that's going to be establishing conditions of health, so diet. And that's usually, there's a lot of data now supporting the use of anti-inflammatory diets, usually plant-based, to work with mental health conditions, assuming we get adequate protein. Because remember, the protein is extremely important, the amino acids, for making different neurotransmitters. Strong exercise of benefit for using exercise in depression and anxiety. Proper sleep hygiene, and then stress reduction techniques for the patients. And I would include in level 1 any psychosocial treatments. So that would include counseling, like psychodynamic therapy. This came out of psychoanalysis. And that really focuses on the unconscious processes that influences a person's thinking and behavior. And then cognitive behavioral therapy is becoming popular. And that's based on the idea that a person's thoughts, not the external world, are the basis of one's feelings and behaviors. Usually this is a shorter therapy, just a couple of sessions, versus the psychodynamic therapy, which is more of a doctor-patient relation over a long period of time. But it's used often to kind of improve different behaviors, to kind of work through different stressors and so forth. So I would include psychosocial treatments as level 1 therapies here. Level 2 would be addressing the physiology of the organs, so supporting the inner neuroendocrine terrain and so forth, either through herbal therapy, acumoxotherapy, the glandular, homeopathy, flower essences, light, sound therapies. And this is where we would typically do in Chinese medicine, for instance, pattern differentiation. So big patterns we often see in mental health disorders would be liver patterns, liver qi stagnation. We often find their pattern of decreased liver detox and bile stasis. Spleen qi deficiency, this would be more of a dysbiosis pattern. with pancreatic insufficiency and so forth. Kidney Qi-yang deficiency would be a low androgens and DHEA, maybe low progesterone. Remember, progesterone has an effect of increasing GABA in the CNS. So this could result in more anxiety or usually more just fatigue and exhaustion. Kidney yin deficiency, low estrogen. Lung Qi deficiency, low thyroid. Heart Qi we might think of as being related partly to epinephrine, adrenaline. And then Shen disturbance could be seen in things like the overactivation of cortisol and the HPA axis, high dopamine, high norepi states like in psychosis and mania. So that would be some of our pattern differentiation ideas. And then finally, level 3 would be replacement, perhaps with hormone replacement therapy. So I should put that on there. But if a person's hypothyroid, we correct that. That's usually the primary hormone we use. But obviously, if they're diabetic, type 1, we're going to give insulin, things like that. So that's replacement therapy. But micronutrients we can think of as replacement here as well. And we know there are several micronutrients correlated with different mental health conditions. So a lot of vitamins, so vitamin A and D, K2, all the B vitamins can have a role in mental health conditions, especially folate, which is B9, and then vitamin C. The vitamin C is water soluble, so again, it's not getting across the blood-brain barrier, but is a general kind of antioxidant. I'm not a fan of vitamin C supplementation. I usually, recommend that people get adequate vitamin C with polyphenols in their diet, so fruits and vegetables and things like that. Minerals, magnesium plays a big role in depression, for instance. Zinc, and if we take zinc long-term over 15 milligrams, let's say over 3-4 weeks, we want to make sure there's a little bit of copper, like 1 or 2 milligrams added to that. And then iron, if they're anemic. Iodine for supporting thyroid, you don't need a lot, but about 250 micrograms a day. It's like 1 kelp tablet, satisfies that need. And then lithium, we'll talk about lithium as a prescription medication. There's a role for very, very low dose lithium as a nutritional supplement, and that's lithium orotate, usually 5 to 20 milligrams a day, for people who tend towards mania, bipolar mania, or maybe psychosis as a potentially helpful remedy, but also depression and anxiety can fit in there as well. I mentioned essential fatty acids are showing a role, for example, in pediatrics, for improving the developing brain. So DHA is a 22 carbon fatty acid, EPA is fish oil, and so that's often they're combined. They're all both part of fish oil supplements usually. But also we can get some conversion from omega-3s in the diet, like alpha-linolenic acid from walnuts and flax seeds and things like that. Amino acids, so tyrosine increases norepinephrine, dopamine, tryptophan, your serotonin, and then GABA as a supplement. Very important, I should just say here, if a person's on psychiatric medication, like an antidepressant or something like that, we should not use amino acid therapy. We risk then overdose or overstimulation of those receptors. Acetylmethionine, this is a methylator, and some people have dramatic benefits with depression and anxiety. Remember, to detox norepi, we think anxiety has high norepi states. To detox norepi, we have to methylate it to epi. And SAMe is a methylator that can participate in that. So this allows you to get your norepi levels down in anxiety. So that could be an important one there. All right, so that's kind of an overview of the therapeutic order, and your decision clinically is going to be to decide, all right, where do I need to intervene here? Again, go back to the assessment section, look at the red flags and all of that to maybe help you determine how aggressive one needs to be in the treatment approach. So here's just an overall table of the medications I'm going to go into and discuss here in more detail in just a moment. But we're going to look at antidepressants, the mood stabilizers, stimulants, anxiolytics, hypnotics, antipsychotics, and then we'll look at stimulants as well. Did I mention stimulants? Yeah, I mentioned stimulants, and then drugs used for Alzheimer's. We already talked about those in the neurology section, so I'm not going to go into that here. And within each of these categories, there are subcategories, so it gets a little confusing. So like with antidepressants, we have the SSRIs, selective serotonin reuptake inhibitors. That'd be things like sertraline, the paroxetine, so Zoloft, Paxil, Prozac, that's the fluoxetine, etc. We have SNRIs. These work with their selective norepinephrine reuptake inhibitors. They keep more norepi around, and that would be things like venlafaxine, duloxetine, so Cymbalta, example there. And then atypical antidepressants, they work more with both serotonin, norepi, but potentially dopamine. Bupropion, Wellbutrin is an example there. Tricyclics like amitriptyline, we'll look at those. They're helpful for depression with pain syndromes, especially neuralgic pain. And then monoamine oxidase inhibitors we don't use as much anymore. Usually these are only given now by specialty providers for patients who are really resistant to all the other meds and haven't responded. And the reason for that is that these have a lot of adverse effects. You have to really watch your diet to avoid eating certain foods. We'll talk about those. If we look down at the anxiolytics, we have several classes here. So we have the benzodiazepines, that would be your classic, Valium, the diazepam, Ativan, Xanax, etc. We have buspirone. We have antihistamines, beta blockers, and barbiturates. So we'll talk about those classes and so forth. So that's kind of a general introduction. So antidepressants are used to treat episodes of moderate to severe depression. The data is actually suggesting that for mild to low moderate depression, and again, we classify this on things like the PHQ-9 and through other sort of clinical tools that we use to grade the severity of depression, that the evidence suggests that the less severe depression, really, there's no difference between the drug therapies and placebo. So we tend to, try to reserve these for the moderate to severe depression. That said, if you go to your doctor and your depression's severe enough that you're going to the doctor for this, they're generally going to put you, recommend one of these medications. Hopefully they'll recommend other things like CBT, cognitive behavioral therapy, and the other level 1, 2, and 3 things, but it's often common that you're immediately given an antidepressant. Ideally, brief periods of mild depression should not be treated with antidepressants. Importantly, and a lot of people don't realize this, it takes between 2 up to 6 weeks to really exert an effect on mood. So patient who says, I took my antidepressant last night, I feel 100% better, probably placebo effect. That it usually takes 2, again, up to 6 weeks for these drugs to have their effect. So that's why we think they're not just affecting neurotransmitters, because within 24 hours, they can actually change your serotonin levels. But it takes longer to have other effects on the brain. So we know that one of the ways these drugs are working is to actually support different parts of the central nervous system, like the hippocampus and amygdala, and make them less sensitive to cortisol and stress hormones. So a lot of people, when they get super stressed over long periods, that actually can induce depression by downregulating their serotonin production and their synapses. And the SSRIs, we think, actually are helpful for that. They protect the brain from that activity. But that takes over a month to kind of gear up and allow that effect to happen. The dose class of medication may need to be changed. So what you often see is that with depression, patients are being rotated from SSRIs, maybe to SNRIs, maybe to Wellbutrin, maybe to the tricyclics like amitriptyline, etc., if they're failing to respond after 6 to 8 weeks on a certain medication. Usually the minimum dose is length of prescription is about 6 months, but I'm sure we all know people that have been on these meds for years, if not decades. I think the first one, Prozac, came out in the 80s, and there are people that are still part of that original group that got Prozac, and there was actually an interesting story on many of them that they're reporting they just cannot get off the medication at this point. They have this terrible rebound depression. So it's almost like their nervous system is just rewired to sort of adapt to that level of medication. There's no tolerance from these drugs, but a form of dependence is being recognized on the drugs. It's difficult to actually stop the medication without any rebound depression occurring. And there is actually something called antidepressant withdrawal syndrome. And that's where you get flu-like symptoms, insomnia, anxiety, nausea, sensory changes, poor balance. And that usually starts within 3 days of discontinuing a medication. And it can last for several months. And I've had several patients that have reported these symptoms right after stopping the antidepressant, whichever class they were on. Now in Chinese medicine, depression has a lot of different, we'll look at the kind of etiology of that, but the liver certainly plays into this. Could also be related to heart. I would also relate to kidney, chi issues, and so forth in some cases. Usually we think of the antidepressants as warming and hot in nature. So over time they can actually have a drying, yin depleting effect. So we can say they try to bring in more light, they bring in more warmth, but that can have a drying, yin depleting effect. The thing to always think is, what kind of light or warmth is it bringing in? Is it bringing the light and warmth from your own soul and spirit, or is it an artificial sort of surrogate light warmth? And I'll just leave that there as a question for you to ponder. SSRIs, first class of antidepressant we'll look at here. So originally it was thought, and these first were researched back in the 1960s, it was thought that they basically inhibited the reuptake of serotonin from the synaptic cleft, and so that keeps more serotonin around, giving a more prolonged serotonin signal to the postsynaptic neuron. Now we think actually there's other effects. So again, we think there's an effect now potentially on improving the response to stress in different parts of the limbic system. And so that's why it takes sometimes up to 6, if not more, weeks for the beneficial effects. Some studies have shown up to 12 weeks, but generally we think 6 to 8 weeks is our usual window. About 40% do not respond to any drugs in this class after 8 weeks of dosing. So that's huge. Not quite 50, but that's a very large percentage. Usually these do not produce any central nervous system stimulation. And again, there's a high potential incidence here of placebo effects. The therapeutic uses are for depression, mild, moderate to severe, OCD, panic disorder with anxiety, premenstrual dysphoric disorder, PMDD, that's the severe mood changes and whatnot that happen in conjunction with PMS right before menses. And for some women, that can be quite debilitating. Bulimia, we'll talk about that later, and then premature ejaculation. So the main drugs in this class would be citalopram, Celexa, escitalopram, Lexapro. So basically, Celexa is what we call a racemic mixture. It has 2 enantiomers, a right and a left-handed form, and both are present in citalopram. Escitalopram only takes the S stereoisomer enantiomer, and it concentrates that because we think that's the one that's more biologically active. So it's really the same drug. They actually were able to sneakily extend the patent by making this form. But a lot of patients say the Lexapro is a lot more effective for them than the Celexa. Fluoxetine, this is the oldest in the class, Prozac. I should say that some of these actually contain fluorine. And fluoxetine actually has fluorine in it. I think that's where the fluoxetine came from. We know that fluorine can actually, it's a halogen, same column in the periodic table as iodine. And we think that in the thyroid gland, it can actually over time inhibit thyroid, increasing subclinical hypothyroidism, which we know actually worsens depression. So kind of a paradox here. But we don't have direct evidence of Prozac inhibiting thyroid, but that's definitely suspected in some people. The fluvoxamine, the Luvox, we have the paroxetine, Paxil, and then sertraline. Some of these are actually what we call controlled or extended release. In other words, their dosage, it's a special capsule. When it's swallowed, it disintegrates over a certain number of hours, so it actually provides coverage over many, many hours and not just a initial surge in the blood. So you'll see CR is controlled release, and then XR is extended release. You'll often see that with the drug names. That's another sneaky way that these companies can extend their patents. So they put a patent out, they do all the research on the medication, and the patent is usually good, I think, for 7 years. And then once that expires, any company can make that drug, the generic version. They can't call it Paxil, but they can make paroxetine. But the companies that make the patents do something sneaky. They will then figure out a way to make a controlled release mechanism, which they can patent again. And that way they have the patent on Paxil CR for the next 7 years again. And so they have sole sort of income from that. So there's unfortunately this huge kind of monetary push with these meds. I think none of us are surprised about that. Adverse effects with SSRIs would be sleep disturbances, insomnia, and sexual dysfunction. This one's huge. So usually low libido, low sex drive. We think that these SSRIs might actually increase production of prolactin from your pituitary, and prolactin suppresses the gonadotropins and would suppress your all your sex hormones. So that's commonly reported by people taking the SSRIs. They just have no interest in sex anymore, no libido. GI distress, and that's partly because serotonin is used actually in the gastrointestinal system as a major neurotransmitter. And so these drugs will actually interfere with that, and that might actually make people with overactive serotonin responses. They generally have like irritable bowel syndrome with diarrhea that might make them actually worse. Weight gain is another unfortunate side effect of this drug class. There is also potentially platelet dysfunction leading to increased bleeding. There's a question mark here about increased fracture risk. That came up as a signal in a couple of studies, but that has not been confirmed. We do see an increased risk of suicidality, though, in children and teens taking these meds. And one of the hypotheses as to why that happens is that a teen might already have a suicide plan, but they are so depressed, they have lack of will to actually do it. Now they take the antidepressant, they feel better for a while, but then they carry out their plan. That's one hypothesis. How accurate that is, I can't say. But that is definitely something to be careful about. And, the important thing to look at with any med is, were there any clinical studies ever done in the age group of patient you're treating? So were 6-year-olds ever tested with these medications? And a lot of times the answer is no, but they are still prescribed in the clinic, which is concerning. I'll say that when the FDA puts out, approves a medication and starts being prescribed, what they then do is they do what they call market surveillance. They actually just collect data from practitioners. There's online reporting sites for adverse events. And then if they start to see a signal that's really concerning, like increased suicidality or increased fracture risk or whatever it is, then they'll do a reanalysis of their approval. And sometimes they'll actually take drugs off the market. And that's happened with several medications, not so much antidepressants, but with other meds. And then increase of spontaneous abortion and pregnancy with SSRIs as well. Fluoxetine, Prozac has been associated with seizure activity. So that's another potential adverse effect. Now there's something you should know about called serotonin syndrome, and that's caused by the use of 2 or more serotonergic medications. So that could be, for example, an SSRI used with an MAO inhibitor, or with taking tryptophan or 5-HTP, or St. John's wort, which actually keeps more serotonin around as well. And that's characterized by hyperthermia, temperatures often over 106, agitation, mental changes, dilated pupils, muscle rigidity and tremor, muscle twitching, it's called myoclonus, and then diarrhea. And we think that's partly from effects on the central nervous system through the hypothalamus in particular. So remember serotonin syndrome is a possible outcome of sort of overdose or excess stimulation of the serotonin. And then there is a serotonin discontinuation syndrome, and that's what we talked about above as the antidepressant withdrawal syndrome. So those are all potential adverse effects. So that's a little on the SSRIs, selective serotonin reuptake inhibitors. Now another drug class here in the antidepressants would be the SNRIs, serotonin norepinephrine reuptake inhibitors. And they work by their name. We think they are working partly through keeping more norepinephrine around. They do have effects on serotonin as well. And these are helpful more for a lot of pain syndromes, neuropathic pain, even migraines with depression. So depression, major depressive disorder, MDD, generalized anxiety disorder, obsessive compulsive disorder, ADHD, chronic neuropathic pain, fibromyalgia. This is a big one. So people that have a lot of sensitivity in the skin, or what we call allodynia, they have pain to normally non-painful stimuli. They can benefit actually from these medications. We think that's partly a norepinephrine signaling problem. And then menopausal symptoms. So these are some of the approved therapeutic uses. Venlafaxine, Effexor, and the desvenlafaxine, the Pristiq, and duoxetine, Cymbalta, are probably the 3 most commonly known ones. We do some categorize the atamexitine, the Strattera, and the tramadol, Ultram, as partly having SNRI activities. Although we'll see that Strattera is used, this is for ADHD, has an off-label use for major depressive disorder, and Ultram is used for pain. It's a weak dual opioid, and SNRI. So we can kind of put those in a separate category, but these first three are the most commonly prescribed. And of those, I think Cymbalta is the one. Effexor may be coming in second. And the Cymbalta, again, has indications for major depressive disorder, fibromyalgia, generalized anxiety, also neuropathic and musculoskeletal pain. Adverse effects here, similar, although have a couple of things that we don't see with the SSRIs. So the sexual dysfunction is still here, although not as prevalent as in the SSRIs. And here, instead of weight gain, there's usually weight loss with the SNRIs. Still GI distress, more tending towards constipation. Can have more hypertension at high doses, increasing your blood pressure, blurred vision, sweating, dizziness, insomnia, sedation. This is commonly reported as well. And then again, increase in suicidality, at least suicide thoughts. Here again, we can get a serotonin syndrome if it's taken with other SSRIs or other serotonin agents. And we already talked about that in the last slide there. Okay, so that's the SNRIs. So the venlafaxine, desvenlafaxine, duloxetine, three most common ones there. And then the atypical antidepressants, bupropion. This is commonly prescribed for major depressive disorder and smoking cessation. So it has a different name. So for smoking cessation, it's called Zyban, but the bupropion for depression is called Wellbutrin. And there are different forms. There's slow release, extended release, etc. We know that this has an action at norepi, but also it works with dopamine. It's a dopamine reuptake inhibitor. It's also a nicotinic receptor antagonist, and that's why it works with nicotine. Now remember, nicotinic receptors are also found at your in your peripheral nervous system at the neuromuscular junction and so forth. So this is actually working more in the central nervous system to kind of work with that. It also tends to turn down the sympathetic response a little bit more, and that helps decrease the craving in tobacco abusers. So used for smoking cessation, depression. Now, interestingly, this does not have the sexual dysfunction that we see in the SSRIs and potentially SNRIs. So sometimes it's used when people are transitioned off the SSRI and they're put on Wellbutrin if they're reporting a lot of sexual dysfunction. Obesity is another use. It actually has a weight, like the SNRIs, a weight loss effect. And then ADHD, there's a question mark there. It's used. I don't think that's an approved use. I think that's more off-label. And then same with restless leg syndrome. Adverse effects would be dry mouth, sweating, tremor, pruritus, rash. A lot of these, it's kind of increasing your norepi and dopamine. So sort of activating in the central nervous system, your alertness, your reward system. Paradoxically, because it blocks the nicotinic receptors, it has a downregulating effect on your sympathetic nervous system in the periphery. So activates your alertness in the CNS, but calms you more in the periphery. So with that CNS activation, there's a higher risk of seizures. Again, increase of suicide thoughts and potentially tachyarrhythmias, increased heart rate. Contraindicated in patients with eating disorders and seizure disorders. So those would be some important contraindications. So that's bupropion, Wellbutrin. I'll just mention one other, and that's mirtazapine. This is an antihistamine. It's very sedating. It's actually not classically an antihistamine. It's called a tetracyclic antidepressant. Its therapeutic uses are for major depressive disorder, anxiety, and insomnia. And Remeron is the brand name for this, mirtazapine. Adverse effects here again: weight gain, sleepiness, dizziness, mania, and potentially low blood count, and increase in suicidality in children. So that's mirtazapine. These are bupropion and mirtazapine are considered to be atypical antidepressants. So tricyclic antidepressants, TCAs, they were first introduced in the 50s. We don't commonly use them anymore. Largely the SSRIs, SNRIs, and the other atypicals replace these. They are used, though, for patients not responding to those therapies and for patients, as I'll mention here, with the pain syndromes. So they work on the norepinephrine serotonin reuptake inhibitors. They also block the alpha adrenergic, which is part of your sympathetic nervous system response on your blood vessels to constrict them, for example. Also, it has histaminic. It works with histamine. So histamine in the CNS, we didn't talk about that much, but histamine actually improves alertness, awakeness. So when you use an antihistamine, it actually makes you more tired. So that's the antihistamines that cross the blood-brain barrier. If they can downregulate histamine, it makes you more tired. This actually has an ability to increase histamine in the CNS, as well as muscarinic, which is acetylcholine receptors. These other effects primarily account for its side effects. So there are a lot of side effects with TCAs, again, which is why they're not primarily used. Very narrow therapeutic index, so 5 to 6 times the maximum daily dose can be fatal. So if patients are suicidal, they're on these, this actually gives them a way of committing suicide, unfortunately. So therapeutic uses would be major depressive disorder, especially for treatment-resistant generalized anxiety, social anxiety disorder, obsessive compulsive panic disorder, post-traumatic stress disorder, body dysmorphic disorder, eating disorders like anorexia, bulimia, borderline personality disorder, which is a personality disorder we'll talk about, ADHD, Parkinson's, chronic pain, so neuropathic pain, fibromyalgia, migraine, smoking cessation, IBS, and narcolepsy. And that's because narcolepsy, we think, is partly related to that histamine signaling being inactive, so it helps to upregulate that. So the most common one prescribed here would be amitriptyline, Elavil, but also we have nortriptyline, Pamelar, doxepin, Atipin, and the dazipramine, which is the norpramine. I don't see that one being prescribed very much. And these others down here again, which I don't see commonly prescribed, so I just kind of put in parentheses. But here, really, the amitriptyline is the one to kind of keep in mind. Lots of anticholinergic effects from these, and that would be blurred vision, dry mouth, urinary retention, constipation, aggravation of glaucoma in glaucoma patients, cardiac arrhythmias, so prolonged conduction through the AV node, so it actually creates what's called a long QRS complex. Don't worry about that, but that can potentially in some patients lead to a very dangerous cardiac arrhythmia. Blockage of the alpha adrenergic receptors can cause orthostatic hypotension. So remember, these receptors are on your smooth muscle, on your vasculature, and when they constrict, they actually help maintain your blood pressure. Well, if you block them, you get vasodilation, you might get hypotension. And that could be a real problem in the elderly. They drop their blood pressure, and then to compensate, the body tries to stimulate the heart to get more cardiac output, and that's called reflex tachycardia. And that could be a real serious problem in the elderly. Here again, sedation, weight gain can be adverse effects, and then sexual dysfunction again. And unfortunately, it can unmask manic behaviors in manic depressive patients. So mania, we think, is related to increased norepi. Well, here we're working with norepi and potentially dopamine, serotonin, all these others. There's something called TCA toxicity, the tri-C, so convulsions, coma, cardiac arrhythmias. That would be like if they're on amitriptyline and this happened, we know it's from the medication. These patients have to be monitored in the ICU for a few days after they discontinue if they have an overdose, for example. Okay, so that's the tricyclics. Even less commonly used, but we should know about them, would be the MAOIs, monoamine oxidase inhibitors. Remember, MAO is an enzyme. There's two types, MAOB, MAOA. They're found in different parts of the body. For example, the gut lining, but also in the brain. And they work at breaking down monoamines, which includes your catecholamines, dopamine, norepi-epi, as well as serotonin. So basically, they're going to prevent those neurotransmitters from being broken down. They're an older drug class. They have a lot of side effects, partly because if you eat foods with what are called tyramines in them, and that would include tyramine-containing foods would be aged cheeses, chicken liver, beer, red wine. Normally, MAO has to break down the tyramines, and if you inhibit MAO, guess what? The tyramines stay in the body, and that actually can create super high blood pressure, it can create cardiac arrhythmias, and so forth. So that can create a hypertensive crisis. So these would all be problems of the MAO inhibitors. Now, because they're breaking down norepi, which is part of your sympathetic nervous system, you might get side effects of dizziness, low blood pressure, again, weight gain, because your norepi actually is needed to kind of stimulate lipolysis. So those would be some of the adverse effects there. Again, these are typically going to be used for non-responsive depression or atypical depression and prescribed by a specialist, usually a psychiatrist or the mental health nurse practitioner who has experience with these. So the Nardil would be an example of that, the phenelzine. So yeah, those are the MAOIs. Again, I rarely, if ever, see these prescribed, but occasionally you still get a patient or two out there taking them. Okay, so that's kind of the summary of the basic antidepressants. Now, depression and bipolar disorder, we'll look at that in a future lecture. These are both considered mood disorders. So the next class of med here would be the mood stabilizers. They're sometimes called anti-mania drugs, and they're used primarily to treat the profound mood swings in bipolar. So most bipolar patients with their long-term medication are usually taking lithium. Lithium salts, in particular lithium carbonate, is used prophylactically for the treatment of manic depressive patients and for the treatment of manic episodes. So it's considered to be a first-line mood stabilizer. It's the first medication used. It's used in acute mania with antipsychotics, which I'll talk about here next, for the prophylaxis of bipolar disorder and for augmentation of any depression treatment. It's effective in about 60-80% of manic and hypomanic patients. It is not a sedative, importantly, not a euphoriant or a depressant. So we actually don't know how it really works. We think it works in a general way by attenuating nerve signaling and just calming down, almost like GABA does, nerve signaling in the central nervous system. Remember that lithium is in the same column in the periodic table as sodium, so it has the same chemical properties. So one idea is that it's kind of competing for sodium, and sodium is your major stimulatory, sort of depolarizing agent in the CNS, so it might actually help to block that activity. We think in Chinese medicine this is more of a cold medicinal and may actually suppress kidney yang long term. We do know, unfortunately, well, let me just talk about the therapeutic uses first. So bipolar, and usually for that it's used in dosages of about 900 to 1200 milligrams a day. Remember going back to lithium orotate, that supplement I talked about, that's a different form of lithium, and the dosage there is like 5 to 20 milligrams a day. So this is much, much higher than what people are using nutritionally, nutraceutically. It's used for acute mania and doses up to 600 milligrams 3 times a day, so that'd be 1800 milligrams a day. And then schizoaffective disorder, we'll talk about that later. That's also, lithium has a use there, 300 milligrams 3 to 4 times a day. Now, this can be toxic. The biggest issue is that lithium really affects your thyroid and your kidneys. And so a lot of the adverse effects are from that. So commonly reported adverse effects would be headache, dry mouth, polydipsia, which is the frequent thirst, and then polyuria, frequent urination, polyphagia, hunger. This is coming from essentially what lithium does in the kidneys is it blocks the receptor for antidiuretic hormone, ADH. It makes that receptor less sensitive. So essentially you get diabetes insipidus. And so a person has all the symptoms of diabetes, but they basically, their blood sugars are normal. So that's one possibility of long-term lithium therapy. So if you have patients on lithium, kind of monitor them for these symptoms. GI distress, fine hand tremors, not fine hand tremors, dizziness, fatigue, maybe skin rashes, and then a patient might be overly sedated. Again, it will decrease kidney and thyroid function. And it's teratogenic in the first trimester, so it's contraindicated for pregnant mothers. Lithium toxicity happens when the blood levels reach over 1.5 milliequivalents per liter of lithium, and that results in ataxia, dysarthrias with slurred speech, coarse tremors, confusion, even convulsions at higher doses, and then acute renal failure. So you have to be careful to monitor patients for renal function. Generally, it's fairly well tolerated, but I have had a number of patients with bipolar who have discontinued on their own their lithium because they felt the side effects were just not tolerable. This is a real problem because they're at much higher risk now for manic episodes. And I knew one in particular who had a manic episode not long after doing that, and he ended up actually causing a lot of accidents on I-5, and he ended up in the penitentiary for 2 years in a state hospital. So this is where we be really careful to kind of have that discussion with our patients about the importance of staying on the medications, maybe doing things to help mitigate some of the adverse effects. But I think this is one of those areas where we don't want to be encouraging the patient to just discontinue on their own without more of a discussion with their doctors. Anticonvulsants would also be used for bipolar, the mania. We already looked at these in the epilepsy section, so these would be the anti-epileptics, and they work through various mechanisms, either blocking sodium or calcium channels or GABA agonists. So the big ones here would be the carbamazepine, Tegretol, the valproic acid, Depakine, and lamotrigine, Lamictal. Each has a different side effect profile. So carbamazepine, we get things like nausea, skin rash, also depression of white cell counts. It can have a block of cardiac conduction that can lead to heart arrhythmias, and then rarely can cause what's called aplastic anemia, which is suppressing all of your bone marrow production of red cells, white cells, and platelets. And that can be monitored actually with a complete blood count. Stevens-Johnson syndrome is the skin rash I talked about, where basically the immune system, the drug triggers an immune response against the hemidesmosomes, which bind your epithelium to your dermis, the basement membrane, and then that connects to the dermis, and so your epithelium sloughs off. That's rare, but a potential side effect of carbamazepine. Valproic acid, here the biggest thing is usually GI issues, maybe some sedation overall, weight gain, rarely pancreatitis, a drop in platelet counts would be thrombocytopenia, fatal hepatotoxicity, liver toxicity, and then agranulocytosis. You would not produce your granulocytes, which are neutrophils, eosinophils, basophils, so you'd lose that part of your immune response. Those are all potential side effects of valproic acid. And lamotrigine, blurred visual, GI distress, again, rarely Stevens-Johnson syndrome. And then this has to be really sort of titrated up slowly. None of these drugs should be discontinued abruptly without the patient being closely monitored. And so again, this would be a discussion for their prescribing physician to work through that. So these would be added in as second line mood stabilizers on top of the lithium. And then antipsychotics might be used for the acute mania episodes. We'll look at those coming up here. They have their own side effects. So, a person with bipolar might be on a couple of these different meds, really can have a very large side effect profile, which is understandable why a lot of patients choose to stop these medications. Again, no, they're going to be at a much higher risk now for a bipolar manic episode. And we'll talk all about that when we look at bipolar disorder. So let's move on and jump to anxiolytic drugs. These are prescribed to reduce anxiety. Now, interestingly, the first line approach to anxiety, we'll look at this again later, is to use SSRIs, not these drugs. These used to be the medications, but now there's a much more reliance on the SSRIs for long-term treatment of anxiety disorders if a patient's going to be medicated. In Chinese medicine, the benzodiazepines, we consider these to be hot dispersing. They might damage the yin, liver and kidney, and beta blockers have more of a cooling effect. They might actually deplete the heart yang because they basically block the norepinephrine and epinephrine. Benzodiazepines, these are the most widely used anxiolytics, but now, like I said, the emphasis is really turning away from these for long-term treatment. Short-term usually is okay, or kind of as needed. We abbreviate that PRN. So as-needed use is usually okay, but the long-term use, we know there is a problem. These drugs bind to GABA-A receptors. They're agonists to the receptor, but they're associated with dependence and drug tolerance, and they can have a very severe withdrawal syndrome upon discontinuation. They cannot be stopped abruptly if you've been on them for long-term. They have to be tapered. This is the primary treatment not the primary treatment for anxiety disorders according to the current guidelines. That said, a lot of people still prescribe them or are prescribed these. For short to immediate acting severe anxiety, they have a role here. So general actions are anxiolytic, so anxiety disorders, panic attacks. They have a sedative hypnotic effect, so for sleep disorders. They induce anterograde or amnesia. In other words, these are sometimes used before a procedure like a colonoscopy. It gives the patient sedation, so they're less anxious about the procedure. And they also get an amnesia, so they basically forget what happened during the procedure. So that way they don't have any traumatic memories, etc., of what happened. So that can actually be a positive thing. Anticonvulsants is a seizure, so these drugs have anti-seizure activity. And we already saw that this is one of the classes of medications that's in the anti-seizure drug section. They have muscle relaxant effects, and they're often prescribed to manage acute drug and alcohol withdrawal symptoms. So those would be the general actions and uses of benzodiazepines. We classify benzos by their action, so they're long-acting. They have half-life of 1 to 3 days. Intermediate acting, half-life of 8 to 20 hours. And short-acting, half-life of 3 to 8 hours. So usually the short-acting are for acute anxiety, acute alcohol withdrawal. So the Muralex is an example of that, the oxazepam. The long-acting ones, these are for anxiety, again, alcohol withdrawal, seizure disorders, muscle spasms, restless legs. Again, not typically used for anxiety anymore, but here's where diazepam, Valium, clonazepam, Klonopin, we have Librium, we have the Doral, and the Tranxium. I think these first two, diazepam and clonazepam, are the most commonly prescribed of the long-acting. Intermediate acting would be your Xanax and Ativan, so alprazolam, lorazepam. And we use that for, again, more acute situational anxiety and insomnia. And the Xanax has an extended release form as well. The adverse effects would be oversedation, prolonged drowsiness the next day, confusion, unsteadiness, unstable mental health states as a result of this. The dependence is a big thing. And so a patient is going to have a very difficult time with withdrawal. So they have to be tapered. And we have to usually go through a month, sometimes more, of tapering the benzo depending on their dosage and how long they've been on it. So that is one for sure. Don't tell your patients, oh yeah, it's okay, just go off your... First of all, you shouldn't tell your patients to ever go off any medications as adjunctive providers if you didn't prescribe that med. But you should also be very careful if they're self-reporting that they're going to discontinue the med, to just warn them that this cannot be discontinued without withdrawal. There's also tolerance that develops over time, so patients will need higher and higher dosages. The good thing about benzodiazepines is we actually have an antidote. Flamazanil is a benzodiazepine antagonist, so it can be given intravenously for anyone that has overdosed on benzos. This is not going to be true of barbiturates, which I'll mention here coming up, but definitely for the benzo. So there is an antagonist to benzos, flamazanil. Okay, so then another anxiolytic would be Buspar, and this is working on buspirone, is working on several mechanisms. We think it works on some serotonin receptors. It's used for short-term treatment of anxiety. It's considered to be a non-benzodiazepine anxiolytic, and it's usually well tolerated. So the typical nausea, dizziness, palpitations, a lot of people, pretty much taking anything, people will report in studies that these kind of symptoms occur. Dry mouth would be more of an anticholinergic effect. No tolerance or dependence, no euphoria, so this is not a drug of abuse. We do think it might increase prolactin, which would suppress sex drive and might contribute to higher body temperature, hyperthermia. But Buspar is generally well tolerated, again, more for shorter term treatment of anxiety. Finally, beta blockers. These are sometimes used to control anxiety symptoms. They are basically blocking the beta receptors, which are in your heart, your lungs, and so forth, which are part of the sympathetic nervous system cascade. We already looked at that in previous lectures. These are not officially approved by the FDA for anxiety, but they're definitely used off-label. So the classic one here would be propranolol, and that's used often for things like performance anxiety. So a person has to go perform the piano in front of a group of 1,000 people, and they get super nervous and their hands start jittering. Well, they might take propranolol, and that actually calms down their whole sympathetic response. So here would be all of the anti-catecholamine effects, so slow heart rates, cold extremities, impotence, dream disturbed sleep, weight gain, will all be long-term effects of beta blockers. We'll look at beta blockers in much more detail when we look at the cardiovascular block, because they are used as cardiovascular medications more commonly than for anxiety. Now the next class here would be the hypnotics. They're prescribed to induce a state of sedation or to treat insomnia. They have a short duration of action, usually several hours. Many carry significant risk of dependence, tolerance, rebound insomnia, disrupted sleep cycles. We have to be very careful, and I should have mentioned this with the benzos. So the DEA has what it called for certain medications, they're called controlled substances, and there's what's called the DEA schedule. And on the schedule, there are 5 classes. So Schedule 1 would be drugs that we think have no medicinal value. We think they're only harmful, and they're completely forbidden, so you can't even get it for research purposes. And that's Class 1. Unfortunately, well, that includes currently things like heroin, a lot of the PCP, all these different drugs that are used recreationally, drugs of abuse, but it also includes, unfortunately, marijuana. So that's the FDA. So that's Schedule 1. Schedule 2 now would be a lot of your opioids and those kind of drugs. Then we have Schedule 3, Schedule 4, and as you go down the schedules, there's less and less restrictions, but they all need, if they're going to be prescribed, they need a what's called DEA number. So the prescriber has to be registered with the DEA. They have to use their DEA number to prescribe them. This is not true of the majority of medications, so like antihypertensives, diabetic meds, cholesterol meds, antibiotics. You don't need a DEA number, you just need to be licensed to prescribe in your state. But these require a DEA number. So these are typically Schedule 4 agents on that list. So Chinese medicine and hypnotics, some authors consider these to be hot dispersing, so long-term use again could damage the yin. I tend to think of them more as sedating and even cooling. So, we could argue these kind of energetics. I don't think anyone's done a really deep study on this. But the benzodiazepines, and I should mention I took this from Claire Stevenson's book, Chinese medicine or biomedicine for acupuncturists. So she has a lot more discussion as to where she came up with those kind of categories. So you might want to read through her notes for that. Benzodiazepines, we just talked about those. Again, they can be used for short-term treatment of insomnia, usually less than 8 weeks, only if the insomnia is severe and debilitating. Again, the problems here is dependence and drug tolerance, and then the withdrawal symptoms upon discontinuation. So the classic ones here would be more short-acting, like Halcyon, triazolam, that's a short-acting benzo. Intermediate would be the Prosom and the Restoril, temazepam. Highly addictive, but also commonly prescribed for sleep, which is not a good thing. And then we have a longer-acting, the Dalmane, for longer-acting sedation. So these are sometimes used more in like hospital settings or institutions with people with really severe sleep disorders. Again, going back to the therapeutic order, and we'll talk about insomnia, so many things can be done on level 1 with diet, exercise, sleep hygiene. Level 2, supporting organ systems using herbal therapies, acupuncture, acumoxa, and then level 3, replacement therapy. So I, as a provider, actually very rarely have to resort to any of these. I do have some patients, though, that have failed pretty much every treatment that they've tried for their insomnia, and so we sometimes do have to resort, at least for short-term trials, to these drugs. I should say benzodiazepines also, we think, really affect slow wave sleep and REM sleep. So they really don't result in a healthy sleep cycle. Benzodiazepine, like hypnotics, these are called Z drugs, and we'll see these in the insomnia section. Again, they should be used for short-term treatment, but I know people now on them for years. So Ambien, Zolpidem, the Zaloplan, Sonata, and the Lunesta. So these would be the 3 classic Z drugs. They're non-benzodiazepines, but they do work on the GABA A receptor, but at a different site than the benzodiazepines. There's different dosage ranges for males and females because we find that females can't metabolize these drugs as well, so there's a lot more sedation the next day after taking them. And that's actually, when the drug first came out, the dosages for males and females was the same, and a lot of women were actually ending up in auto accidents and whatnot the next morning after taking these, and so the FDA had to step in and readjust that. And there's different dosage ranges depending on if we're trying to aim for sleep onset or for sleep maintenance. So again, we'll talk about that in the insomnia section. A lot of side effects similar to benzos, a lot of prolonged drowsiness the next day, confusion, memory problems, nightmares, increased risk of depression, increased risk of bone fractures from falls, rarely hallucinations, suppressed respiration. Sleepwalking has been associated with the zolpidem, the Ambien. In fact, there's been stories of people in high-rise buildings just walking right off their balcony, sleepwalking and falling to their death after taking these. Drug tolerance, independence again, and then potentially we have a signal of maybe increased mortality as well. So these are, again, fairly commonly prescribed, but not a great option for insomnia. And I'll mention in the insomnia section a lot better options. Antihistamines are sometimes used as hypnotics. They are approved for insomnia, but really we have questions about their long-term effects. And some of the recent data is suggesting these are definitely not things you want to take long-term for insomnia. And that would include things like hydroxyzine, the Vistaril, promethazine, Phenergan. Some people actually take Benadryl for sleep. That is not approved by the FDA, and we know that one actually severely disrupts sleep rhythms, and over the long term has all sorts of adverse consequences. These are generally considered safe, but a lot of drowsiness the next day, and a lot of these antihistamine symptoms, anticholinergic symptoms as well. Barbiturates, I'll just mention, they are not widely used anymore for sedation. We did see phenobarbital, luminol used for epilepsy, for pediatric epilepsy. These are pretty much have been replaced by benzos. They have a lot of tolerance. They have a lot of withdrawal symptoms. There is no antidote for barbiturates like there is for the benzos. And the big thing here is respiratory depression. So people overdosing, you take it with alcohol, you could die because basically it paralyzes your diaphragm, or the brain centers that regulate respiration, and the diaphragm won't be moved, so you can suffocate. So usually this is used for epilepsy and not as a hypnotic any longer. So psychostimulants we'll come back to. These are used in the treatment of ADHD and ADD. They actually are centrally acting. They get into the central nervous system, and they increase basically sympathomimetic effects. They increase norepi, potentially dopamine signaling in areas like the prefrontal cortex. And what's very interesting is in the ADD, ADHD patients, although they have a lot of hyperkinetic activity, you think, why would you want to give a person like that who's running around, they can't sit still, anything, stimulants? Well, it turns out if you do brain scans on them, their prefrontal cortex is essentially asleep. It's not being stimulated, and the levels of norepinephrine and dopamine are significantly lowered. So the idea is these medications upregulate the prefrontal cortex, and remember that's your higher executive center, so now it can start to sort of repel and suppress unwanted impulses coming up from the brainstem and other regions of the limbic system. So it has sort of an overarching regulatory role on a person. These are very yin depleting over time. We can say they're really having a cooling effect and dispersing effect. The actions of the CNS stimulants really, again, are to increase norepi from presynaptic terminals in the CNS, also at higher dosages increasing dopamine. We do find that they decrease the substance abuse risk in patients with ADHD, and we think that's because they increase dopamine. And the therapeutic uses are for ADHD, narcolepsy, and sleep apnea. Now, interestingly, most of these are derived from amphetamine. A lot of people don't know this, but a lot of these drugs, the dexmethylphenidate, dextroamphetamine, which is a version of amphetamine, is Adderall. And then methylphenidate, which is Ritalin, also Concerta. These are all derived essentially from amphetamine. So we're giving kids amphetamine, basically. And usually the dosages are adjusted, so it's not like taking the street amphetamine, but it's kind of, we think, working pharmacologically on the same receptors and so forth. Caffeine is considered a CNS stimulant. This one's working more on the adenosine receptors, and that sort of tricks neurons into thinking that they can keep firing and keep functioning. And then modafinil is an interesting one. This is an indirect acting adrenergic agonist. It's off-label for ADHD, used for sleep narcolepsy and sleep apnea. This one is not derived from amphetamine, but it has sort of similar effects pharmacologically. Adverse effects of these would essentially be hyperactivity, palpitations, tachycardia, so you're kind of stimulating the sympathomimetic effects as well. hypertension, rarely cerebral hemorrhage. Lots of potential herbal interactions. So anything with an amphetamine or an epinephrine-like effect, so that would be anything with synephrine, for example, and that is found in chenpi and chingpi, jirsher. These are the tangerine peel, bitter orange, jirsher, and then ephedra, the ephedra alkaloids, and then other herbs that are used in Chinese medicine to stimulate kidney yang, the rokong rong and other kidney yang tonics, all potentially could interact with these in a negative way. A lot of these increase testosterone, and testosterone increases dopamine, and that could sort of further augment the effects of the different drugs. So that's something to think about there. And then there are non-stimulants, so they're for mood, they're for attention, but we consider them to be non-stimulants, and that would be atomexetine, the Strattera, and this is a selective norepinephrine reuptake inhibitor. It hasn't been studied in kids under 6, but it's preferred in children who can't take the stimulants, and it must be tapered if discontinued. So this is like another one that needs to be tapered, Strattera. Intuniv, the guanfacine, I haven't used this one. This one actually is a sympatholytic. It reduces the peripheral sympathetic tone. So that would be another way of addressing hyperkinetic activity potentially. And you can read about some of the adverse effects there. So these would be in that class of sort of treatments for ADD, ADHD, psychostimulants. Finally, we'll look at antipsychotics. They also go by the name of neuroleptics and major tranquilizers. And they're used primarily to treat schizophrenia, manic states like in bipolar mania or psychosis. And that's patients with sort of a state of feeling of grandiosity, paranoia, hallucinations, delirium, nausea, severe nausea and chemotherapy. And that's because the nausea centers in the brainstem use dopamine as their primary neurotransmitter. So these drugs block dopamine, and they can actually downregulate nausea, interestingly. And then there is a use for intractable hiccups in people. The MOA of antipsychotics is to decrease dopamine, specifically D2 receptors. There's several different receptor types for dopamine in the mesolimbic system, so this is going to be in the limbic areas. They're going to decrease serotonin via a different serotonin receptor, the 5-HT2A receptor. Remember, serotonin has dozens of different receptors, and this is one specific one involved in psychosis. Has anticholinergic properties. They block muscarinic receptors, and then antihistamine properties, as well as anti-alpha adrenergic. So those are some of the mechanisms of actions of antipsychotics. In terms of actions, they decrease what are called the positive symptoms of schizophrenia. Positive symptoms are hallucinations and delusions. So they have a calming effect on the central nervous system without depressing intellectual function, unlike barbiturates, which kind of calm the CNS, but they really severely depress cognitive function. Little effect on what are called the negative symptoms of schizophrenia, and that would be blunted affect, anhedonia, loss of interest in life, apathy, social withdrawal, impaired attention, cognitive impairment. So we'll look at that with schizophrenia. Schizophrenics often have both positive and negative symptoms. These drugs work better on the positive, not as well, although we'll see there's two different classes, generations, and the second generation of antipsychotics do have effect on the negative symptoms a little bit more. And then the antiemetic effects, they block the D2 receptors in the brainstem, and that might be used to prevent nausea in cancer chemotherapy. So if you have a cancer patient working with, they're on an antipsychotic, that doesn't mean they have schizophrenia or history of psychosis. It might be for their nausea. So they're classified in two generations. The first generation are the traditional or typical neuroleptics, and they work more on the D2 receptors primarily. And these have much more of an effect on the positive symptoms of schizophrenia, but they have a lot of extrapyramidal symptoms. So remember, the extrapyramidal system is really the basal ganglia. And remember, basal ganglia uses dopamine as a neurotransmitter. So if you inhibit dopamine, you're going to create essentially a situation that's just like Parkinson's. So these can create severe movement disorders. And these agents are classified as either low or high potency. So low potency agents would be the chlorpromazine or thorazine. and then Melloryl is another one there. And then high potency agents would be the fluorphenazine, Prolixin, the haloperidol, and so forth. So you've probably heard of these. These came out in the 60s, and they're associated with the classic kind of mental institution where people are highly sedated on different meds. These are usually first generation antipsychotics. Since that time, the pharmacologists have targeted the meds a little bit more towards the 5-HT2A receptor. And so there's what are called second generation or atypical neuroleptics. And they have a lot fewer of these extrapyramidal symptoms, so a lot less movement disorders and more of an effect on the negative symptoms of schizophrenia. And that would be things like the aripiprazole, the Abilify, the Clozaril, clozapine, the olanzapine, Zyprexa, quetiapine, Seroquel, the risperidone, Risperdal, and so forth. So these would all be second generation antipsychotics. So if we look at their general adverse effects, can occur in all patients. In fact, the adverse effects are significant in up to 80% of patients. That's been discovered through different surveys. General effects would be drowsiness, confusion, again, very commonly weight gain. So this is a really bad thing. As we saw, only the Wellbutrin and the SNRI is really the only drug class of all of these that doesn't have significant weight gain associated with them. Raised blood sugar and diabetes, acne and rashes with much sensitivity to sunlight, hypotension and arrhythmias, disturbances in temperature control, rarely hyperthermia, disturbed liver function, having lack of periods, or even because of potentially increased prolactin, galactorrhea, milk discharge, and then impotence and gynecomastia. So this would all be potential adverse effects of both classes. There are also the antimuscarinic effects of dry mouth, blurred vision, constipation, difficulty urinating. The extrapyramidal effects, again, are going to be more pronounced in the first generation, the older, the typical neuroleptics, and that's going to result from the problem in the basal ganglia with dopamine. So dystonias would be sustained repetitive muscle contraction, results in twisting or repetitive movements and abnormal fixed postures. It's not uncommon to go ride public transportation and see people that are on these different medications and they have all these bizarre movement disorders. Dystonia could be one of them. The akathisias are inability to remain seated due to motor restlessness, and they have to just keep moving around. Parkinson-like tremors, so all the Parkinson symptoms, so resting tremor, bradykinesia, rigidity, that usually sets in within weeks to months after starting the medication. And then tardive dyskinesia are involuntary movements like lip smacking, chewing movements. Unfortunately, this one can sometimes be irreversible. So patients who develop tardive dyskinesia, they stop the med, it continues. These are by no means a magic bullet solution, but they are used, like I said, in the schizophrenia psychosis patients to help manage their care. I'll talk a lot more in detail, again, about other potential approaches we can think about there in addition to this. So that's a summary, hopefully not too long, about all of the major classes of medications used in psychiatry and mental health conditions. Now, in the following videos, we're going to jump into each mental health disorder separately.